Dr. Bat, please stop sharing your... Dr. Bat, please stop sharing your... Dr. Bat, please stop sharing your... Please stop sharing your...
Yes. 1 minute, I connect the YouTube. So good evening. My name is Dr. Mugambi. I'm the Assistant Secretary General, Kenya Medical Association, and part of the team that's been organizing the Physician Health Program, along with Kenya Psychiatric Association and the the Clinical Psychologist Association of Kenya. We welcome you all today for this session. I will be welcoming my colleagues who will be co-hosting this session with me, Dr. David Wairoto and Josephine Ohas. Dr. Somba, our chair of the Committee of Physician Wellness, will be online in a few minutes to also welcome you all. We thank you also for gathering today. So I take it over to Wairoto. Before I do that, please kindly do follow the rules for this meeting. Ensure that you keep your mics muted until we allow you to ask questions. In the meantime, we will launch a poll that we would like you to give us an answer if you're willing to give an answer. In between, we'll also have a small poll to understand our level of trauma, so that we are able to guide the next CMEs that will come up in our next sessions. So I'll launch the poll. Do click and give an answer. It's only one choice for that. I'll give it a few minutes as David prepares. We'll have Dr. Samba first, and then David will be next to introduce the speakers of the day. Thank you. Dr. Samba, you can unmute. Dr. Somba, you're unmuted. You can.
Can you hear me?
Yes, welcome.
Oh, you can hear me?
Yeah.
Hello?
We can.
Oh, you can?
Yeah.
Good evening, everyone. My name is Dr. Somba. I'm the chair of the physician committee in KMA. It's a privilege and a pleasure to be with you today. The few other occasions I've missed out because of a few challenges here and there, but I'd like to welcome you all today with a very, very important and very important session. And we have eminent scholars who are going to handle this issue. We all know the problem we are having. We all know this is an unprecedented kind of a challenge that we are having. We have never had this before. Something that's affecting everyone and everything and all of us. It's actually a big challenge. So as we listen to our speakers, very prominent and eminent scholars, Professor Muthoni Maathai and Dr. Rachel Maina. Maathai is a psychiatrist. Rachel Maina is a clinical psychologist. I want to believe that this will be a meeting of the minds, and I'd like to express to everybody to come up on board and give us their views on this issue. The topic today is a timely topic, vicarious trauma, which of course affects all the workers, health workers, and actually is affecting us a lot. So I think with those few comments, karibuni sana, and feel at home in this meeting. Hello? Hello, did you get me?
Yeah, Doctor, you've got a new.
Yes. I must confess that it's a bit sad I'm doing for the very first time. So I might be having a few challenges here, but trust me, I'll pick it up very quickly. I think the next one I'll just be as good as everyone else. So we have issues of physician wellness, which of course you all know, doctors and health workers, they could leave the sick. And in some occasions, they could become sicker themselves, and there's no protection. And I think this particular topic is very, very important for all of us to understand. I will now hand over to Joy Mugambi to continue from there. Thank you.
All right, good evening, colleagues. So my name is Dr. David Wairoto. I'm Vice CME Coordinator, Kenya Psychiatric Association. Karibuni sana kwa the KMA, KPA, and CPAC CME on vicarious trauma. We see already we have 405 participants. Let's invite more colleagues. It's a very interesting topic. So our speakers are going to be Professor Muthoni Maathai. Professor Muthoni Maathai is a senior lecturer in the Department of Psychiatry, University of Nairobi. She's a senior researcher, and she has her key skills are clinical psychiatry and community psychiatry. Our second speaker is going to be Rachel Maina. She's a clinical psychologist and a mental health researcher. So karibuni sana, and please prepare your questions after the session. Thanks. Over to you, Joy.
We'll start with our first speaker, Professor Maathai, as we prepare to share our findings from the poll. Professor, from our poll, we asked, do you as health workers feel stressed and anxious at your workplace? We've got 72% saying sometimes, 17% saying most of the time, and 6% saying always. 6% said no. So that means this topic is quite key at this very moment. And we'll urge those who are coming in, check down there. There is a push and written polls. Take the poll. We'll have another poll launched after our professor gives her topic. So welcome, Professor. We'll unmute you shortly. David, you can help me with unmuting Professor. David?
Oh, good. Hi. Good evening, everybody.
Welcome.
Yeah, I've already been introduced. I'm really fine. Good evening. So excited because I'm meeting for the first time so many colleagues who I haven't seen for years. Number one, Dr. Soba Kivungu. We come a long way. And it's an amazing story.
Yeah.
And I also see another colleague from Nanyuki, where I come from, Dr. Bhat. Hi. Yeah. So and then I see. I am really excited. Thank you so much for inviting me. And I would like to share my screen and project a few slides. I just made a very few slides. I didn't have like so much time, but I would like to share these slides with you. Let me see, how do I share screen? Good, I think I am sharing the screen, am I? You have to tell me because I'm not very sure. Let me see, put it on.
Yes, you are.
Is that
Yes,
correct?
you
Let me see. Oh, good. Okay, thank you very much. So I was told to talk about vicarious trauma, which I will mention. Basically what I prepared was what we call the first line health responders in this COVID-19. And I'll be very brief. I won't go into all the details of what we are facing because this has been talked about over and over again. But I want to remind you, but you all know that doctors, nurses, technicians, ambulance drivers, support staff, we are the front line responders. Sometimes other people in the security forces and many others actually. These are people who have direct contact with patients who are infected or who may be infected. And this COVID-19 has become a never-present threat for us. And we are the ones who cannot run away, we can't hide. This is an anxiety, this is a fear-provoking situation where we can't flight or flee or hide. So it is, and the fear is real. It is not exaggerated. Nobody can tell you you're exaggerating. It's not that bad or anything. We know this because this is a highly infectious disease. We have seen what happens to what has been happening around the world. And the threat to our health workers is it's global, but it becomes even more acute in our low resource countries where there's inadequate access to the personal protective equipment. Now, the psychological effects that we're talking about for frontline responders, additionally to the physical threat, they're exposed to psychological stress, distress as they interact with patients and as they treat patients. So this includes anxiety, burnout, depression symptoms, and the exposure to the traumatic experiences of others predispose the health workers to secondary traumatic stress, or what we call vicarious traumatization. And I will talk about the symptoms later. There's something else which is not really a disorder, but which has been described commonly in this pandemic and in the last one, the SARS pandemic, and that is what is called moral injury. And that is when you have to make a decision that violates your moral ethics. I think we talked about that recently in another forum, and this is where you have to decide who gets that one ventilator which you have. Who gets that one ICU bed? And somebody was saying, is it your MP or is it a 20-year-old young man? And is it your friend who is old like us, some of us, you know, who already have other morbidities? So these are issues that are likely to face doctors particularly, because they're the ones who have to make these decisions. And this is what is referred to as moral injury, and can also further predispose to traumatic stress. Now, the important thing everybody is asking is, are we preparing our health workers to respond to this crisis? Do we have guidelines? And one thing is that the World Health Organization has been dealing with this kind of crisis before, maybe not pandemic in the form that we have, but in epidemic forms. We've had the Ebola, we've had the SARS, the MERS, and there are guidelines. And if you go to the WHO websites, you'll be able to see some of these things. So everybody who is in charge somewhere should be able to go to access these sites and say, are we preparing? Do we have clear roles? Because these are very important. Do your health responders have clear roles? Are you sure what it is you're supposed to be doing? Or are you just there, confused and running around, not knowing what to do? The other important thing to prepare yourself, you need to explain to your family, you need to tell them what is happening in a realistic way. You don't have to be wondering every time, like, and what am I going to say to them when I get home, or if I don't get home? Because that is the other question that comes into this as one of the issues that need to be addressed. Whether to go home or whether to actually reside where else, if you're really directly involved in the management of patients who are high risk. Now, the other thing is, does the head of the department, the supervisor, have they established a plan of working hours, duty rotations, and how to access and they use the PPEs? I've heard a lot of people saying, yeah, we talk about PPE, we don't have them, but even if we have them, and those who have them says, we haven't been taught how to use them, you see? So these are issues that actually, a lot of you I know here are managers in your different departments and hospitals. And then health workers need to know in every area where they're working, what happens in the event of exposure? What will happen? Where will I go? Who will take care of me? And I think we need to look at all these issues, particularly if you're in that level of management position. Now, stress during crisis, and this is any crisis, and this is been looked at before in other crises. One is the fear. And like I said, this fear is real. Nobody is exaggerating this fear, but there are, of course, ways to stop this from overwhelming us. There's anxiety, there's burnout, there's depression, and there's the vicarious trauma, which is a secondary, also called secondary traumatic stress. That is the stress you get from somebody else's traumatic experiences. Now, we need to recognize as doctors, as health workers, these signs and the conditions in yourself and in other responders, because you need to think, okay, now I think I'm getting burnout. I need to do something about it. Where can I get help? Who can I talk to? Burnout is that feeling of extreme exhaustion and being overwhelmed from the activities that you do, from your professional activities. Now, symptoms include sadness, depression, apathy, easily frustrated, you're snapping, you're angry, you're blaming others, you're irritable, and you stop having feelings. It's like you feel it before, it's too much. You don't feel it. People are there, and you feel indifferent to what is going on around you. Sometimes you feel isolation and disconnection from others. It's like you have a wall between you and others. Sometimes you don't care anymore about your own self-hygiene. And these are symptoms that were described a lot in Wuhan, tired, exhausted, overwhelmed, feeling like you're a failure. There's nothing you can do which will help. You're not doing your job well. You need, in some cases, people are resorting to alcohol and other drugs and sedatives and tranquilizers and to cope. So you need to recognize the symptoms of burnout before it gets too much. Now, the vicarious trauma, and this is where I'm supposed to talk about, I said it's a stress reaction and symptoms resulting from exposure to another individual's traumatic experiences, rather than from exposure directly to your own trauma. But it is what happens a lot to fast responders, whether you're an ambulance driver, picking people who are screaming, dying, or whatever, whether you're a doctor who is sometimes confronted with the pain of others who are seriously ill or dying, the trauma of the relatives who come along. Sorry about that, let me dismiss that. And so a secondary vicarious trauma is a trauma of helpers, those who help others who are traumatized. And it presents with excessive worry or fear about something bad happening, the premonition of something's going to happen. You get easily startled, just like in traumatic PTSD. You feel on guard, watchful. You have the physical and physiological sign, the palpitations and the other symptoms of stress, abdominal discomfort, heaviness of the head. The other thing is you get nightmares or recurrent thoughts and images about the trauma situation. Sometimes you can't get rid of these thoughts and you get images. It looks to you as if it is happening. You see again and again all these images of these people who are dying around you, who are on respirators. And the feeling that the trauma that is happening to others is also your trauma. So very briefly, let me talk about the coping techniques. And I really want to advise you to really check these out because they're really very, very important. And the first line recommendation has been for all responders and not just responders, most people to do self-care. And there's a whole guidelines on self-care. And for this particular pandemic, we are saying people should take breaks from watching, reading, listening to horrible news and stories and social medias and hearing about the pandemic repeatedly because that can only make your situation worse. So that they know we have all these WhatsApp group. Please don't have to read them all the time. Now the other one is to take care of your body. Deep breathing, what is called diaphragmatic breathing, stretching, meditate if you're a meditator, and pray if you're a prayer person. Because we're different. There are those who prefer to meditate. There are others who are very religious, but you do need some quiet space inside your head. And you need to think that there is some communication with something bigger than yourself. Eat a healthy and well-balanced meals. Drink plenty of water. That is important. Exercise regularly, indoors or outdoors, whatever you can. Whatever time you can, set aside some time to do some movement, body movement. It's really so important. And try to get plenty of sleep. Avoid alcohol and drugs, including hypnotics, as a way to reduce stress. Don't be like, I'm so stressed, I need a whiskey. Please, then don't do it at that time or other drugs. Remember that as health providers, we are prone to getting addicted to hypnotics. So be very careful. Make time to unwind. Try to do some other activity that you enjoy. I don't know, we all have different things. Something completely unrelated to your profession, something different. And then most important, connect with others socially. Social distancing, we are talking about we should be talking about physical distancing. We want you to distance yourself from others, but socially connect. We are very lucky that people have a lot of access to media. Please do connect, make calls to your friends, make calls to your family. Now, there's something called a worry window. And somebody was asking, what is this? We're going to worry. There's no question about it, but you don't want to be worrying all the time. So some people have found it useful, even in psychology, to set aside a worry window time. Take a notebook. Say, my worry window will be every day between 4 and 4:15. Any worries that I have, I'm going to shift them to that time. That's my worry window time. Sit there with your pen, try and worry actively. Because what happens, the more you try to actively disconnect, block worries, the worse it gets. It's like the story of the white elephant. Try not to think about the pink elephant. And you find that you can't. It keeps on coming. So try and find another way. Now, deep breathing, I want to repeat this because it's so important. It's part of the psychological first aid strategies. And there's very many videos. I know a lot of people say they're not very sure how to do it, but there are very many YouTube videos on this. I would advise you to check one, learn how to do it regularly. And I want to conclude by saying one thing. Debriefing. You have to be careful with debriefing. If you don't know how to do it, don't. Let people talk to each other as they would like to. Don't push people to talk about their experiences, because we found that debriefing can cause more post-traumatic stress disorders, particularly in people who are not prepared for it. So I would advise you to be careful about that kind of debriefing, but I want to advise people to have somebody that they can trust, somebody they can talk to. Now, before I just finish, let me just say that from our department, we written a proposal, which is now at ethics, where we want to offer group psychosocial support to health providers on the front line. So when this goes through, for time being, we have requested only to do it in Nairobi. So we may not be able to take it to Nanyuki for the time being, but maybe we can expand this, but we hope we'll be able to get in touch with you. And we would like very much, of course, to work with KMA and KMPA. I'm a member of both. So we'll be getting in touch with you once we get the ethical approval for this. Thank you very much. And I will be available to answer any questions. I want to escape and remove, stop presenting.
Thank you very much, Wangari. I'll hand over.
No. Mothoni. It's not Wangari. I mean, not that I don't honor Wangari, but yeah.
I'm so sorry.
No, it's okay.
Yes. So thank you so much. We appreciate that. I'll hand over to David to take over as I share a survey for us to take. Just like the last one, we are asking, have you had any training on avoiding managing stress at work? Then David will take over once you've answered that. We'll give feedback once our next speaker is through. CPD points, a link will be shared on the chat. So those who need CPD points can access that and keep filling it out so that we get to know who was here and which CPD points to provide you.
Thank you, Prof. Mathai. That's a very wonderful presentation. So our next speaker is going to be Rachel Maina. Colleagues, please remember to fill in your questions in the Q&A, please. We'll ask some questions to our senior colleagues. So now the next speaker will be Rachel Maina. Karibu, Rachel.
Where do you fill the questions?
We'll put up the poll after the next presenter. So we'll close it for now.
Okay.
Our next presenter.
Sorry, we have a small hitch. Apologies. All right, we can be taking questions. So please write your questions in the group chat. We can have Prof ask us some questions. We can have Prof, answer some questions. Thanks.
And I don't know. Hello?
Yes, Dr. Somba.
Where do I put the question? Can I ask mine direct? Because I don't know.
That's okay, Daktari. That's okay.
Yeah. First, I'd like to thank Professor Mudoni Madai, and also congratulations. She's actually a pride of Nanyuki. Yeah, she comes from Nanyuki, and she's a lady from Nanyuki, and we are very proud of her. And a beautiful presentation. Now, I was wondering, what is the role of the institution? Because all this you have said, they are all on individuals. Individual must do this, individual must do this, you must check your health, you must not drink whatever, and you must do exercises and things like that. What about the institution? The institution have any role on trying to mitigate this vicarious trauma? Because the institutions are actually, if you're working for a institution, there must be some role they can play to assist the health workers.
Thank you. Thank you, Dr. Samba. The institution has a very important role, and that is why I say that that one is the preparation of the health providers. That's why I need. They must have very clear roles, and that is the role of the institution, to make sure that your health providers who are on the front line must have clear roles. They must have clear duty allocation and time allocation. It is also important for the institution to ensure that the health providers get adequate rest and a quiet space to rest. They need that. Two, if they have questions, if they want somebody to talk to, that this is available, whether it's one-on-one, on telephone, on other digital framework, they must have somebody to talk to. They must, and of course, like everybody is saying these days, we must ensure that our health providers who have direct contact with high-risk patients have personal protective equipment, and they must know how to use it. These are all roles of the institutions. I mean, we don't work within a vacuum, and there are the things you can do for yourself, and they're the things that the institution must provide. And in some areas, we're also saying that it is important to provide our health providers with a space where they can spend time, particularly if it gets really serious, so that they don't go.
Okay.
Oh, we can't hear you.
Yeah. I can't hear.
She's gone. She's gone off kidogo.
Okay.
I think what we'll do, we now have Rachel with us. We can proceed with the next presenter. David, if that's okay with you. And then I will take more questions for Wangari.
Not Wangari, but Mudhoni. Okay. There's a question that's going to follow up, so maybe I'll follow that question with that later.
Yes.
Okay, so.
I think, Professor, we can't hear you, so
Can you hear me
we'll
now?
get back. Yes, now we can hear you. I think we'll get back at the end when we are doing Q&A.
My microphone, my da-da.
Yeah.
Sorry, my microphone just went off and I just went on talking to myself. I hope I had talked about the roles. Had I talked about the roles of the institution?
Yeah.
What I was, Professor, just before you
Yes.
go.
Yeah.
Well, what I had in mind was incentives and the feeling that the incentives with the health workers in terms of remunerations, in terms of urging them to fight on, because there are soldiers on the front line. And some of them are worried that if something happens to them, that's the end of the story. And usually nobody remembers them. So now, how do you go about to make sure? I know you can. We're going to say there must be a law or something, things like that. But what are you going to do? These are soldiers, and they are out there. How to give incentives so that they can come on fighting, knowing that the park is well covered. For example, now if I go there, no problem, and then something happens, I know my family is covered. So this is what is the institution role on these health workers, apart from just a place to sleep, wait, and so on. The regulations are poor. They give the PS, yes, but these people, these are fighting. I'll give a short example. The soldiers who fight out there in the army, in the fighting, these people, they go out with the whole heart, knowing that the back is covered completely. And when something happens to them out there, they are declared missing. They're not declared dead, missing for almost 8 years. Now, this is what we're talking about. They're declared missing. So 8 years is when now they say, yes, somebody passed on. And the salary, whatever in relation, the family, they just continue getting that money throughout for a long time. This is what need to be discussed in as far as the health workers are concerned. Because we're out there fighting, but there's no cover and there's no help. So I don't know where maybe, I don't know where you address that, but that is a critical situation whereby you are asked to fight, yes, with people and so on. But what about immigrations? And what about me? So I think that's my concern really. And I think this should be there to look into these issues. Thank you.
You're right, Daktari. This is a concern because we know that some of our health providers, some of our doctors don't even have a health cover, an adequate health cover. So they're even asking now, if I even get this, where will I be taken? Where will I be cared for? Who will pay for the cost? So these are real issues, and I'm glad this KMA is here. I hope KMPDU is here as well, because these are issues that need to be addressed from that level. And definitely, when you know that you're covered, your back is covered, it is true that you have less stress. That is quite correct. Yeah.
So thank you very much, Professor and Dr. Somba. We'll move on to have Rachel Maina present something from the clinical psychologist's angle on the same topic. So Rachel, you can unmute. Yes, you're unmuted. If you have something to show on the screen, please do.
Can you hear me?
Yes.
Yeah, we can. We can hear you.
Okay.
Rachel, you can start talking as we wait.
Okay. So how are you all doing?
You're well.
Karibu.
Health
As we wait for Rachel, we can
undertakings,
probably. Yes.
and some of them can build up in terms of creating resilience.
I think we're having challenges with hearing you, Rachel.
Some of them can build strengths and weakness. In terms of creating resistance.
I can't hear you.
Can you hear me?
No, we can't hear you, Rachel. We are having challenges hearing.
Can you hear me?
We can't hear you.
Can you hear me?
As we try to sort out Rachel. Rachel, we can't hear you. David, you can probably go through the questions on the chat as we try to sort out Rachel's sound system.
Okay, that's fine. So, Professor, there's a question which has come in. There's someone who is asking, what are the signs and symptoms? What are the signs of symptoms of vicarious trauma, which we should watch out for in our colleagues? That's the first question.
Mm-hmm.
Yes, the second question is, I know Badia is asking whether psychological first aid and group sharing can also be used also to try and avoid to avoid the vicarious trauma. And then there's someone who is asking whether it's better we involve the psychological interventions at the beginning of care instead of actually waiting for them after, as an afterthought.
Okay, let me first answer those ones, sir.
Okay.
So vicarious trauma, how do you recognize that your person working next to you, your brother, your sister, whoever, your colleague is having vicarious trauma? First of all, some of the signs you know is that they are very, very alert. They are watchful, they are alert, they are easily startled. Unajua ile kushtuka. So
Prof, your mic.
So we lost Prof's mic. Prof, we cannot hear you. So David. Hello, David.
Yes, Joy.
We can probably share the results of the second survey, and then I will move on to the third survey as we wait for Prof to sort out her mic, because I think it's a general problem that's not being heard all through.
Okay, you can share. You can share the
yes.
results. We go through.
So most people polled that they had no training, 77%. And I think we can, as we prepare Rachel's slide, we can take the second survey if you're okay with that, David.
Yeah, that's okay.
But we have a lot of psychiatrists with us, so even some of the questions can be asked alongside. So is Prof back?
Not yet.
Okay. But Rachel's slides are almost ready. I'll launch the second poll. Those in attendance, please do take it as Rachel awaits to log in. So we're asking, what techniques do you use to cope up with stress? Do pick out as many as you feel you usually use when you are stressed out. We've had a lot from Professor Mathai on various ways of coping. I know we have various ways of coping. There are those times you get angry, you confront, you may engage breathing exercises, physical exercise, eating and snacking, sleeping, substance abuse. So we want to know what happens when people get stressed out there. Food is said to be a good relief, isn't it, David?
Sorry, my headphone, my microphone went off. I'm sorry if you didn't hear anything. I have a problem.
We did hear, but
we
we
did hear.
are okay. We've been
I was
moving on with
talking and
survey.
talking. Okay, just continue. Yeah, okay. Do you want me to repeat what I said?
Yeah, kindly.
Okay, I'm so sorry. Please, if nothing happens, somebody wave so that I see. Okay. What I was saying is, how do you recognize vicarious trauma in your colleague? One, you notice that they are very alert, they are very fearful, they are afraid to get into situations, they are avoiding certain situations, and they also get easily startled and they start withdrawing. That was the answer to that. The other one was about training, psychological preparedness. Yes, that is so important, because if you have people who are well prepared, then you can even consider debriefing, but otherwise you have to really be careful with that one. So, and psychological first aid, absolutely important. And I said that one of the things we'll be doing in our intervention, which I talked about, is in the first 4 weeks, we are going to be doing psychological first aid. And the other one is group support. I hope I have answered the questions.
Thank you very much, Prof.
Thank you, Prof.
So we are ready with Rachel's presentation. I hope she's ready with her sound. And we've ended the poll. We were asking what techniques do people use to cope with stress. It's very interesting. So Prof, these are the results. Most told that yes, physical exercise was one of the main coping strategy.
Yes.
We've got a lot who are praying.
Yes, that's good. Yeah. I think
of the other quite commonly used coping strategy.
Yeah, this is expected, and I'm glad to see that a lot are doing physical exercise, even with the limitations that we have, and that is really good. That will really keep you going. Don't stop, not now. Sleeping regular hours, and try, I know this is difficult for doctors because of our timings, try and sleep at the same time every day and to wake up at the same time every day. This is very healthy. But I know that sometimes with all these things, it becomes a bit complicated. That's good. Prayer is good. Even crying is good. I mean, even crying is okay. It helps you if it makes you feel good. Confrontation, verbal or physical, is not very healthy. Breathing exercises are very good. So I think going by this, we're not doing too badly, doctors.
That's nice. Thank you.
Okay.
Thanks a lot, Prof. So we'll bring on, I'll put that down, and then we will share Rachel's slides, and we'll have our next presenter. We are so sorry for having had issues with her mic, but even her slides have been shared, so we'll have that up shortly. So Rachel, probably you could test your mic 1 minute as we prepare to bring this up. So Rachel, you're free to go. So we can't hear Rachel, though her colleague will take over and help her do that presentation. Rachel? Liz Ahemba? You're unmuted.
Hi, everybody.
Hi.
Now I'm not prepared.
Hi. Now I can hear you.
Oh, you're on, Rachel.
Hi, Liz.
I think
Yes, go ahead.
Rachel
Go
is-
ahead. Go
Yeah.
ahead,
Go
Rachel.
ahead, Rachel.
Oh,
Yeah, we can
finally.
hear
Thank
you.
you. How are you all doing?
Yeah, we are
Very
well.
fine.
Okay. So, okay, cool. My name is Rachel. Thank you so much. Sorry for the technical hitch. So I'm going to cover briefly about vicarious trauma, and my professor has covered quite a bit. So I'm just going to dwell on things that she hasn't. So a bit of introduction when it comes to vicarious, when it comes to psychological trauma. First of all, is that psychological occupational risks that we probably go through when we attend to the COVID patients or any other people who have gone any form of trauma is in form of secondary traumatic stress, compassion, fatigue, and vicarious trauma. And something I need to note down here is that not everyone undergoes the same work-related traumatic experience and happens to have vicarious trauma or compassion fatigue or STS. Some people have vicarious resilience or vicarious post-traumatic growth as a result of working in such situations. So we don't really assume that every healthcare worker who's dealing with any COVID patient or any COVID-related situation is undergoing a form of stress that is not going to make them better. We have to know that there are some people who will actually come out of this unscathed and actually better people than they were before. So it's important to know that as much as people may have emotional distress because of being in that situation, have any form of suffering or pain, there are guys who come out of it unscathed. So when we go through it, we can either experience compassion fatigue or compassion satisfaction. Where compassion fatigue, we have the reduced ability to dispense our own duties because of the distressing situation by the undergone when attending to a client. So vicarious trauma occurs during the normal work routine of the provider when they are empathizing or engaging with the distressed patient and they get to undergo any form of behavioral cognitive changes that make them not to function as well as they were functioning before. So I present to you a model. I call it CS/CF model. CS is compassion satisfaction and CF is compassion fatigue. So I present a model whereby to have a good professional QOL, quality of life, you either have the two. And in compassion fatigue, that's where you develop vicarious trauma. But in compassion satisfaction, that's where you develop vicarious resilience, or what we have to have what's called post-traumatic growth. The vicarious post-traumatic growth. So with compassion satisfaction, you have positive aspects of helping, you have pleasure and develop satisfaction when working with these people. You may be related to providing care, the response that you get from the patients make you have a form of a satisfaction in what you're doing and confidence in what you're doing. It may be related to the system where you're working, there are enough PPEs of helping provide for you enough protection that you want. It may be your relationship to your co-workers, with your supervisor in terms of the support you give, both emotionally and also in terms of in form of belief about yourself, especially after training, when you're very sure about what you're doing, then you have positive beliefs about yourself, and that leads to compassion satisfaction. Where vicarious trauma comes in is where you have negative aspects of helping people. So with negative aspects can be also generated from providing care where you feel like taking care of this particular person is going to expose you to the same kind of pandemic, and probably you're going to home and expose the same to your loved ones, your kids, your husband, your wife, your parents. It may be related to the system, where the system requires you to still attend to the people you're working with without proper PPEs or without probably standard procedures for doing that, and makes you feel inefficient in working with these, and may develop fear and negative beliefs about yourself and your ability to work, and hence the negative emotions, negative beliefs, and leads to self-doubt, which may actually lead you to have some form of trauma or work-related trauma. So something else that probably my professor didn't mention is that not everyone who goes through trauma or who is attending to these patients of COVID actually get the same experiences out of it. We have moderators of trauma, and these come from your present schemas. A schema is a sort of a belief that you have developed over the years that relates to how you see yourself right now, how confident you are about working with these particular patients. Moderators with trauma can be in terms of stigma or beliefs about it. We have had cases of some healthcare workers refusing to attend to someone because when they have just a simple cold, because they believe like this particular cold could be a precursor to COVID-19, and hence so something else of COVID actually the stigma beliefs gets, and also in terms of social support system, if you go home after attending to a COVID patient or from hospital, and when you go home, no one wants to get associated with you. You are present in your neighborhood, everyone enters their doors. You are past an assault and you want to go to your neighbor and borrow experience, but there are also positive support systems in terms of your children understand when you come back from work, it's no longer our system as usual where we go, we hug, we have dinner together. It's like mommy or daddy first has to go, shower, has to probably undress first before they can even say hi physically to their loved ones. So those are their support systems that support that, because having a positive or negative support system can alter whether or not you develop that kind of trauma. And also, if you've had a history of trauma or illness, it might exacerbate or make you to be more susceptible to getting vicarious trauma. And also economic and healthcare situation, the stress of it all may add onto it. So in general, vicarious traumatization is the enduring psychological consequences of exposure to the traumatic experiences of healthcare workers, trauma survivors, or people who are victimized because of it. And mostly it occurs among people who are continually exposed to traumatic situations, and this includes the COVID-19. So how do we make sure that we don't develop vicarious trauma? First, let's start with resilience planning. So there's something that you can do individually, there's something that people can do within their organizations, and there's something that people can do when they're under supervision. So individually, you can use something we call a professional quality of life. It's a sort of a self-screener that you can easily Google and use it to assess where you are. Sometimes it's hard to know whether I actually am stressed out or not, because probably of our own definition of stressed out, or probably how you feel, because you may feel that this is normal, I'm not undergoing any vicarious trauma. Try and find out whether you have any form of vicarious trauma or any form of compassion fatigue. So home, we have the quality of life, what I've written there as ProQ or L, that can help you plan where to put your energy to increase your resilience, and by showing you where exactly you're not doing very well. We have organizations, Dr. Mathai has talked about these, that can help in maximizing positive aspects of ourselves and reduce the negative aspects of helping people. Also, we have supportive supervision, which Dr. Mathai has talked about in the form of a bad buddy system. Like within yourselves, you can form a sort of support system as healthcare workers, checking up on each other, forming a time and a day to just sit down and discuss among yourselves how you're doing, what are the ups, what are the downs, how can we better support each other as we go through these. Vicarious traumatization, according to the symptoms that Dr. Mathai has talked about, this is how you can manage yourself. So first of all, it's good to educate oneself. Like what we are doing right now in this CME, what are the work-related psychological traumas and how do they present? So, and I'm going to talk about it. And also it's good to assess yourself. I've introduced a tool that you can use to monitor yourself, assess oneself, monitor your own severity of work-related trauma, coping levels, and ways to increase resilience. And then you can take action by creating a strategic plan to increase resilience and seek psychotherapy services if need be. There are a lot of helplines that have been shared through the ministry. Life is a sort of a self-screener that you can easily Google from Infant Health whenever you want to seek help, and also knowing yourself through the self-assessment and creating action plans to take care of your resilience or to ensure that you're still functioning optimally can help in these as well. So when it comes to self-management, what exactly am I looking for when it comes to vicarious trauma? I'm looking for cognitive symptoms. You can have intrusive thoughts, maybe preoccupation with the trauma, and also changes in concentration. You can have changes in remembering. You may have memory problems. You may have concentration or attention problems. And you may think of yourself as not worthy or inadequate in doing this, so despite being trained about it. So it's good to monitor that. What exactly is going on in my thoughts? Emotional life without written symptoms, including feelings of survivor guilt, like or irritable powerlessness. You may feel also have snapping at people around you. You may feel guilty about probably surviving, especially when one of the COVID-19 patients passed on. And you may feel like just system as because probably someone has passed on, or probably someone has not really gotten well according to what you wanted. The materials manager is able to do that. So feelings of hopelessness, helplessness may come in. Through the ministry, you want to seek to ensure that cancer self-intrusive thoughts, maybe preoccupation, things that probably even don't go out with any painkiller, gastrointestinal. This is where you need to really take good care. And also somatic gastrointestinal and behavioral responses like status, all those. It's important as much as and we have nightmares. It's important. PTSD can also come as a result of vicarious trauma, and it's important that you be aware of them. And also spiritual beliefs, you may start questioning your belief system, like how does God let this happen? Isn't he big enough? Isn't he powerful enough? Doesn't he also God let this say that he heal? So such kind of social isolation, mistrust, and conflicts. Like we can be able to monitor all these symptoms on our own, but then again, it's important that we monitor these symptoms among ourselves. Like try to find out, like, is the person taking is my next health undergoing any form of we can be able to monitor probably irritability. Are they always complaining of any pain symptoms? Are they probably overly hypervigilant about everything? Are they having startle responses? Important that you monitor these among yourselves and also among other people. So how do I take good care of myself? How do I make about turn in having these symptoms? So Dr. Mathai has talked a lot about management in terms of the other thing is to try as much as possible to symptoms. I get enough sleep. CDC recommends that you don't work more than 4-hour shifts. But then again, it's important that you get 6 to 8 hours of sleep. It's important to try as much as possible to leave work at work. Once you exit that gate at the hospital, it's important you leave it there and you'll attend to it in the morning and go home and attend physically, emotionally, and cognitively everything that you're going to undertake at home. So spiritual nourishment, Matthew has talked about that, which is really, really good. And for people who are going through that self-doubt about when it comes to as much as their spirituality, it's important to give love. So hopefully it's possible to get enough sleep. A leader that can help in realigning your thoughts to your spiritual beliefs. And again, take pride in your work, helping someone who's traumatized. You are there, you are helping this person. No matter what the outcome, it's important that you take pride in that work. Relaxation exercises, Dr. Matthew has talked about deep breathing, so you can do that. Massage, artwork, at home. So spiritual meditation responds on the chat line about singing. Yes, that can work. Taking long baths or showers right through that self-doubt before bed helps your body to relax. Probably nature walks if you're in a place where you can do that despite the curfew. It should be really important that you do that as well. The other thing is about, especially when it comes to cognitive sort of symptoms, self-confront. Ask yourself, so as much as you may dwell in probably self-guilt, thoughts of helplessness, of hopelessness, it's important to self-confront and assess your anxiety, and growth can come out of this when you do that. So I'm trying to prove exercises. Whom am I trying to impress? What am I trying to fix? Am I depending on someone else to validate my sense of self-worth? What is the growth potential in this situation? Kufikiria hivi inanisaidia vipi? So self-confront is something you don't need to see a psychologist for. It's something that you can do it within thoughts, or probably you can take a picture yourself these, and this can help in growth, and especially in growth towards vicarious post-trauma growth, instead of dwelling in it in a very negative way. So I think those are my thoughts when it comes to being able to get enough sleep. There's so many helplines available for anyone who wants help, and they're free of charge. We are doing telecounseling, and it's important that you get in touch so that we help you through this. Let's help each other through this. Thank you. Ask yourself.
Thank you, Rachel, for the presentation. So now, because most of us we missed it, I'll do the slides for everyone to be able to see.
So what am I trying to prove?
So that's Rachel's presentation. So she defined what vicarious trauma is, and it occurs during the normal work routine of the provider when she or she empathizes and engages with a distressed patient. This form of trauma is manifested when the provider experiences negative cognitive changes when viewing his or her work. That's the model she introduced us, the CSCF model.
And yeah, there's so many.
So that's the compassion satisfaction.
Thank you.
So that's the EAT model: educate oneself, assess oneself, and take action. The EAT model. We can do a Q&A. Prof, are you on? Prof Madai. Now we'll go to Q&A. Dr. Josephine, are you there? You can start the Q&A, please.
Yes, I am. Good evening.
Good evening.
Daktari, I think when you're presenting, we were not seeing any slides. We would just hear your voice.
Oh, you're not seeing any slides?
We have not seen anything.
Okay, let me go back, Paul. We
I think it is okay. We can share the slides later from Kenya Medical Association so that we can move on.
Okay,
so basically, this from this presentation, there have not been questions. Basically, what people were talking about was the slides. So they've not raised questions, but then there are some questions that were asked in the first presentation. There was something about fear of being quarantined. So I think Dr. Rachel could probably address that. And then there was a question about whether there is a suicide hotline that is available where health workers can call when they start having suicidal thoughts. And then there was a question about how to manage family anxiety about secondary exposure for workers who have to come back home. And then there was also a concern about spouses working together. How do they manage the stress when they have to come back home when they're both frontline workers? I think that was it. I don't know that she's gotten all my questions. I mean, all the questions. Dr. Rachel?
What was that last question again?
The last question was about spouses that are both frontline workers. How are they supposed to deal with that issue when they come home, or the stress that then ensues when they are back home?
Okay.
Should I repeat?
So the stresses that healthcare workers when they're a couple?
Yes.
Yeah. Okay.
Did you get all the 4?
Okay, so okay, so I got the question on the stresses that come about when both healthcare workers are their spouses when they go at home. What usually happens? I got that.
And then there was one about how to address the fear of being quarantined. Hello? Doc, did you get the second one? You did, right? Okay. And then number 3, do we have a suicide hotline?
Yeah. What's
where
the third one?
workers can call?
Oh, Prof is back on, eh?
Yes, yes, I'm on. Yes.
Okay. So I got a few questions for you.
Mm-hmm.
So the first question is from Kingi, one of us.
Yeah.
So the institution leaders and managers are also facing the same anxiety towards the pandemic. Plus,
Yes.
of course, a lot of pressure from senior management. So what is the best way of them and to cope? Even the guys in the ministry.
Yes. First of all, I can imagine that they'll be even under more stress sometimes at this point when we haven't reached that point where there are not so many health providers in direct contact, but they are expected to give us answers. We are expecting answers from them. And the most important thing for them is to plan. We need plans, and they must communicate, and they must look for help. And I know a lot of them are. It's like saying that you don't have to carry this alone. Nobody had experience in this from before. We know that there are few people who went to Libya, Liberia for Ebola, and look for resource persons. Let people come together and discuss this. This is more or less also what we're doing, and let this go back to the ministry. Let Dr. Njuguna also get the feedback on this so that we support him. I think that is the best we can do, because the other one is to get the experience of those countries that have been there before. And I think yesterday there was a webinar which was presented by Ludbeck. I hope colleagues from psychiatry also had a chance to listen, because it was really good, because the Canadians have experience from having been affected by SARS. So I think this is I believe this is the way to go. But wherever you are, whoever you are, self-care skills are for everybody at this time, even for administrators.
Okay.
I don't know whether I can answer better than that.
Yeah, you've done very well. Thanks. Another question is how are the healthcare workers going to prepare and manage their families' expectations? Because you see, they are going to the health facilities and then they go back to their families. So what approach?
మీ ఫోన్ లో జూమ్ వచ్చింది ఆన్ చేయండి.
Yes.
Oh, okay. Okay, let me talk about
మీటింగ్ ఉన్నది, మరి పాయింట్స్ ఇస్తాడో లేదో తెలియదు కానీ
okay. Meeting is not working too well. Now, Dr. Wairoto, this is a question that came up even in among other health providers, and one of the in other countries, it's an ongoing question. What do you do with your families? In some countries, they have provisions where they've provided the frontline responders, not everybody in the hospital, with facilities, adequate facilities, not dormitories, adequate facilities where they can stay and their families feel safe. And that is why I say that one of the things that is really important here is that communication with your family, even the little ones. Communication, let them understand that this is happening and what has to be done. But in our situation, we still have this, the providers are going home. Actually, what I've heard is some of the frontline workers have sent their children to the village. And they said, okay, that, because of that, close contact. And luckily for us, our children are used to going to the village during the holidays, so they think it's just another trip. But I think we have to be very ingenious in how we deal with it. When you get home, like you're saying, try as much as possible to make sure that you don't carry, it's like your clothes, you're not carrying your clothes back to your home. And really, no good answer to this. but communication. From our point of view as mental health providers, we really believe that communication is important. You just gauge it to the age group. It's different for each age group. And that's all I can say. Did I disappear again?
No, no, you can hear me?
Okay, I can hear you now.
Yes,
yeah.
so
Yeah.
yes. Now another question from one of our colleagues is what about the married couples where both are frontline health workers? Any special considerations for them when both of them are frontline workers?
My consideration on this would be communication. Let them talk, because in that case they can really talk about their fears. They can be there for each other. They can be more supportive. They can, you know, how was your day? They can be also practice self-care together, and they can also be accountable to each other to try and stop this frenzied posting in social media of all kinds of story, and that feeling, you have to read them. You're reading WhatsApp, you're reading news, you're watching news. The minute you get home, you've come from hospital, throw away your TVs, people. Get rid of them. Listen to the radio once a day or read the newspaper online. I mean, it's not going to help you to learn how to cope by listening to the drama of TV. It's not going to help you to read every dramatic message or potential cures which have no evidence, which are not evidence-based and no background. So I think that there is room for couples to support each other more than ever. Maybe after this, they will come out of it loving each other more than they were before. Maybe.
True.
I don't know whether Rachel is able to add something. Rachel, would you like to add something to that? Somehow she's having problems with her microphone. Rachel, are you able to add something? Not
Rachel? Rachel? Rachel,
Okay.
Can you add something? I think she's having some technical challenges.
Yeah.
Now, what about the medical personnel, Prof, with pre-existing psychiatric conditions?
Why?
Are there any special recommendations for them? Maybe
Hello,
anxiety,
Dr.
depression?
Matai.
First of all, they have to, you have to make sure you're on treatment, not just health providers. You must maintain your treatment. Particularly at this time. They are more likely to be more vulnerable to relapses and exaggerated anxiety disorders also. And they're very interesting. In this presentation yesterday, they said that because we know that some of the mental illnesses are now associated with a lowered immunity.
Yes.
That means if you are not on treatment and if you're not getting treated and you have depression, bipolar, your immunity might be low and you're more at risk of getting a COVID infection. So I think it's really important to maintain your treatment. Very important, even for our patients.
Maybe just before you go, Prof, there's a question by Naeku. She asks, how about the use of vitamin A, C, and D supplements in addition to the other physical measures?
Hey, that is for the biochemists and physiologists and immunologists in our... Can somebody answer that? I'm a psychiatrist, for heaven's sake. Is there anybody from the Department of Immunology here who can help us out? I don't think I can help with that one. I don't even want to say anything. Maybe there's somebody who can answer that, then. Oh, but they're all muted, so maybe put it on the chat.
We'll put it on the chat.
Yeah.
So there's another question from one of our participants.
Yes.
They've asked what's the difference between vicarious trauma and secondary trauma?
Actually, mainly they are actually the same. I would use, they are used interchangeably, even compassion, fatigue, and so on. So some people say secondary vicarious trauma is the secondary trauma that you get as a health provider, as a helper, whereas secondary trauma can be got by other people who are not, like caregivers may also get secondary trauma. So that might only be the little maybe different, but people we use it interchangeably. But vicarious, because it is, you are in the helping profession, in the health profession, then you get it from your patient.
Thank you so much. Maybe one last question, Prof.
Yes.
There's
yes.
someone who has commented, they're saying the fear of being quarantined is the biggest fear at the moment.
Yes.
So maybe you can comment about that.
Yes, it is true, the fear of being quarantined. Why are people afraid of being quarantined? They're afraid of being quarantined for several reasons. One, they are facing that every day, that fear of I could be infected or not. As opposed to somebody who is already infected, who is now saying, okay, I'm infected, now they're fearing whatever. So that is one, you are faced with that fear. Two, the stigma. Unfortunately, like in several other pandemics, and unfortunate also because this is one pandemic where we find that it doesn't know money, it doesn't know class, it doesn't know whether you're a prince or a pauper, but there's still a lot of stigma associated with being diagnosed with COVID. So even being quarantined causes stigma. And then we've had stories where they're saying, yeah, people are quarantined with people who, other people, and then they didn't have, and then they get, so they're all this. So maybe we didn't plan the quarantine system very well, so that has its own stigma. But that fear, and it's interesting that in this Canadian experience, they found that people who had excessive fear of quarantine are also more likely to get depression afterwards and anxiety disorders. So it is a real fear, but so this is the one time when you as a person, the community is more important than your individual self. So we are all making sacrifices here. It is a sacrifice. There is a big fear, but people will just have to do it. But we also have to plan our quarantine better so that you don't feel like I'm going in there and then I'm going to get infected. And we should stop stigmatizing people. Stop talking badly about and mentioning names. Oh, so-and-so has been quarantined. You know that, that contributes to their stigma.
Maybe one last concern, Prof. Oh, sorry.
Yeah, sorry. So we also have our distinguished Prof. Atwoli, Lukoya Atwoli. So he can also comment a bit.
No,
welcome, Prof.
Thank you very much. Thank you, Dr. Madhai, for a wonderful presentation, and Rachel for a wonderful presentation. I have been following quietly and enjoying the discourse. And I liked what we are ending on, that in dealing with stigma against this pandemic, people with COVID-19, the psychiatrists have a huge role to play. And secondly, all the practitioners have a huge role to play. Because what has been happening is that we at some point are dropping the ball and allowing this to be treated as a criminal thing, as a criminal justice thing. It is our responsibility to advocate for patients. It's our responsibility to advocate for a public health approach and reduce the stigma against our patients who may have been infected with COVID-19. You're seeing stories now of people escaping from quarantine. It reminds me of how people used to talk about people escaping from a mental hospital, and same kinds of stigma. And so we need to be careful that that we don't perpetuate that stigma as practitioners, and that we don't then make the intervention worse than the disease itself. So thank you very much, colleague.
Thank you, Prof. Rachel, can you hear me? Rachel?
Yes, yes, I can.
Maybe you can comment a bit.
Yes, I can, Wairato.
Okay.
Okay. So I'd like to add to what Dr. Mathai said about healthcare workers who are quarantined, practical steps of what healthcare workers come from healthcare workers who are probably not having taken care of everything at home, especially like if I'm being quarantined today, who will remain with my child at home, who will take care of them, they're all alone. Probably if both their spouses are healthcare workers, they are in and out of the house, and there's no one to take care of the kids. Some practical things or steps that they can take is that if you're a healthcare worker, you know there are chances that you might the things that you think you may develop fear of. Of what and how can you take care of them? Just someone that you can entrust your child to, probably their grandparents. If it's something to do with provision, is there a way you can make sure that one or the other they are provided for enough within the house? When it comes to probably taking their grandparents, if it's your content, is there someone that one or the other if you're there to help people, and it's important that you think about the fact that even when you are quarantined, you are also helping people by protecting yourself. Then you have yourself in quarantine, but the fact that in the disease. So it's also in the helping profession to help yourself and be in quarantine for a short time. Something else I would like to talk about is someone asked whether there is a suicide hotline in place.
Yes.
Especially for healthcare workers. At the moment, I know we had the Befrienders Kenya, which used to offer a suicide hotline. So at the moment, we have hotlines offered by the mental health, the Ministry of Health, and we have one by Thalia. And the number is this is for healthcare workers. The number is 020-790-3939. The number is 020-790-3939. So if you can contact that number, then you can, as a healthcare worker, you can get all the psychological help that you may need, as well as referrals to important people who can help you in this work. As we do this to 39 together. Yeah, and then the other question was how couples who are both frontline workers can deal with the resulting stress at home. I know this is, you can imagine if both helpline has referrals to snapping in the house, there is a loss of memory, probably of important things that are running within the house. And it's and it's important for each one to have like an accountability. Then the other question was partner. Sometimes it's not easy to think through things when people are mad or there are anger issues within the house and things are not running well. So it's important for them to have friends that they can talk to. The buddy system that was alluded to by Prof. Mathai. So I know this is once in a while to make sure that they are okay, they are well taken care of. And that's the only way that two couples living together and the healthcare workers, they can both be in a space where they can still be loving and respectful for each other. So have you can imagine family partners contact the hotline number that I've just said it out loud. And this will help anyone or these couples who are healthcare workers working with COVID patients. I think those were the questions allocated to me, unless there are others.
There are two questions. So how are mental health workers talking to the government about improving their contact tracing exercise? The comment is the manner which it's being done is turning the infected and affected into pariahs in the community. can those guys who are tracing these guys, the contact tracers, can they be sensitized about safeguarding the dignity of patients? Then the other question is talking about trauma. There is the fear of contracting the virus from asymptomatic patients, and then the issue of being reinfected by those who have turned positive after being declared negative. Can comment about that? That's for both Prof and Rachel.
Okay, let me talk about this trauma, because the fear of contracting the virus from a symptomatic person. That is the fear that everybody have. We don't know who has the virus in their symptomatic phase and not. So that is a generalized fear that everybody has. It's a real fear, but the thing is that it is important to not dwell too much on fear, and that's why you need to do all these things. You need to do relaxation, you need to exercise, you need to talk to people. Don't dwell too much on the negative media and news, because, I mean, how do we know? We say that there are, is it 280 what? Today, I don't know, but how do we know, really? A lot of patients, people may be out there symptomatic, and it's true, you could get it on reinfected. So this is a fear for health, more for health workers, because if you work in a hospital, you're coming into contact with people and you don't actually know whether they're infected or not. You may be in a low risk, what might be considered low risk, but it's the same everywhere. That's why you need a bit of protection, particularly in the hospital. Even if you don't need the whole PPE, when you're dealing with patients, you need to get at least an N95. You need to follow the same thing that everybody is saying: wash your hands, wash your hands, wash your hands with soap, disinfect, disinfect, disinfect. We don't know. So I'll let Rachel do the one political one. Is she talking?
Okay.
I can see her face is talking. I think she's also talking.
We can't hear her.
But we can't hear you. Rachel, we can't hear you.
Yeah, but
So I'm seeing Dr. Patel. Thank you for the comment. He's an immunologist, and he's saying if you have a healthy, balanced diet with fruits and vegetables, you don't need supplements. Thank you,
Okay.
Dr. Patel. So I hand over to Dr. Gitao, Catherine.
Can I have a comment?
Yes, please, Dr.
Yeah, let me make a comment. I want to say thank you very much for these eminent scholars. I think they have taken us quite far. We have learned a lot of things, but the support is there. I think one message that has come straight is that we need support. That's the take-home message: support, support, support. Let us support each other. Let us support all of us, and let us be our brother's keeper. And that's the motto of the Physician Health Committee. Hello, can you get me?
Yes, we can hear you.
Yeah, so that's the role of the Physician Health Committee. We advocate that we become our own brother's keeper, and we support each other. Because with support, we can go very far. And we have a hotline, KMA. Anytime you have a problem, or you see, or you feel, or you see your colleague is having issues, you can always get in touch with me or KMA, and we'll definitely come there and help him. I was just wondering, wondering out there, there is something called vicarious legal liabilities. I don't know if you guys have heard about that, because it's something about legal, vicarious legal liabilities, litigation on issues. If you are the provider of a service and your employee gets into trouble, you are vicariously liable for the health of that employee. I don't know whether we need a legal interpretation on this, but my feeling here is that the institutions are vicariously liable for the health of their workers. And I think that should be looked at, especially when we have these issues now of COVID and other. And we say this is something that is difficult, and the fear is real. We all know that. And just the fear of the disease, sometimes also, but our main shield is actually knowledge. Once you have the knowledge, then that can really help you and protect you. So as any of this, this let us support each other in all ways, and let us be our brother's keeper. And I think with that, I think I'll let say thank you very much for your time. David?
Yes, Dr. Gitao, thank you, Chair. Now to Dr. Gitao for closing remarks.
Okay, thank you, Dr. Wairoto. I hope you can all hear me.
Yes, we can.
We can hear you.
All right. Thank you to our speakers. We've really had a good interactive session this evening. We've learned a lot, and we've learned a lot about burnout, vicarious trauma, and how to, most important, take care of ourselves and identify the symptoms of these various conditions. And very grateful that we have hotlines that we can reach out to. And also very grateful to Dr. Madai for the work that you're proposing to do amongst the healthcare workers. We look forward to participating in that study. And then Rachel, we appreciate the hotline that you've given us. I hope physicians can reach out and be assisted when there's need. I'll not take too much time because we spent a lot of your extra time already. But I'll just mention that we shall share these slides, and if there's need for help, you've heard that there's a hotline for KMA, and you can call us or even just email. Okay, so grateful to all the participants for having filled in the surveys, and we have learned a lot from that. So thank you all, and we look forward to the next webinar. We'll probably be focusing more on our children and how they've been affected by COVID-19, and looking for the best way forward on how to manage their anxiety levels as well. So have a great evening, and thank you. Back to you, David.
Thank you, Dr. Gitao. Thank you, colleagues. I think now we can end. Please remember to fill in the Google form for your CPD points. The slides will be shared. Thank you. Good evening.
Well, again a lot.
Oh, okay. Ndio maana nikuconvert hiyo. Really? Application not found.